itself, okay, like Emerin and Lamin, which we're going to talk about in a few slides, or elements of the contractile elements, the actin-myosin themselves. So when you have limb-girdle muscular dystrophy, it could be a problem in the extracellular matrix, in the membrane, in the contractile apparatus, and even in the nucleus. And we were just saying that most limb-girdles are somewhere in the middle. So in other words, you don't die within 6 months, like in some very tragic cases. Unfortunately, most of them are not asymptomatic, like a lucky few who just have elevated CPK and no symptoms. Most limb-girdles are somewhere in the middle. And again, we were just reviewing that limb-girdle muscular dystrophies are now defined genetically, okay, unlike 50, 60, 70 years ago when it was described phenotypically based on the type of weakness. So now we talk about limb-girdle muscular dystrophies. If it's autosomal recessive, it's 1. Sorry, autosomal dominant, it's 1. If it's autosomal recessive, it's 2. Limb-girdle muscular dystrophy 2. And again, this slide just shows the current model with all the limb-girdle muscular dystrophies, and the list accumulates from year to year. So limb-girdles, like I said, are rare, but they're much more common than other rare neurologic diseases. So the prevalence is 15 to 20 per 100,000. And that's not all that different from MS, myasthenia gravis, and those kind of diseases. Obviously, it's not migraine or stroke, but still out there. So in your career, you actually might run into it, even if you don't become a neuromuscular expert. So for example, if you're a neurointensivist, and you have a patient with limb-girdle muscular dystrophy who unfortunately gets pneumonia and ends up in the ICU, which happens inevitably to some of my patients every winter, you'll have to manage these patients and understand how to successfully extubate them and what's the pattern of ventilatory weakness in these patients. So this is one case. So this is in honor of our pediatric neurologists who are here. This is actually a real case from real life. There was a 4-year-old boy with normal birth and developmental history who presented to his PCP with some stomach pain and nausea. So of course, what do? They got LFTs, and the LFTs were very elevated. So the pediatrician lost his you-know-what and did a whole GI workup, and then they also sent off a CPK, which turned out to be, I think, like 16,000. Remember, the cutoff here at Downstate is 220. And the kid was not like a massive bodybuilder, right? He was 4. And even if you're a massive bodybuilder, you don't CPKs of 16,000. If you're a massive bodybuilder on steroids, maybe, but not in general. So the boy denied any weakness. He had no difficulties climbing stairs, running with his friends. There's no family history. So the question is what do? You have a kid who seems, quote, unaffected, right? Neurologically intact, who's got a CK of 16,000. So this is an error. And we repeated it more than once, right? It wasn't like the lab, whoops, they shook it or something before they tested it. So it's real. So what do you do for this kid, right? Now you could argue he's completely asymptomatic, right? Yeah, you could argue, don't you want to know what's causing this, right? So the question is, first of all, is it muscle or not? That was your first question, right? So you have elevated CPK, usually in the peripheral nervous system disorders, right? Frequently in muscle, but rarely in motor neuron disease and even neuropathies. But when you have an extremely elevated CPK, what do I mean by that? When you have a CPK of over 5 times normal, it's almost always muscle predominance. In other words, motor neuron disease, yeah, you might have a CK of 800, 1,000, 1,200, but it won't be 16,000. Because to have a CK that high, muscle really has to fall apart. And the only way it's going to do that is when you have primary muscle pathology. So in this case, we were pretty convinced it was a muscle process. So then we get to, is it a muscular dystrophy? Is it a myopathy, right? And if it's a myopathy, is this a myositis? Now, again, you have a kid who's unaffected. So the odds that it's a myositis are pretty low, right? People with myositis, which I'll talk about, I think, on Thursday, right, will complain of muscle pain, myalgias, weakness usually, right? Which this kid didn't have. So pretty unlikely. Obviously, 4-year-olds can get myositis, right? Which we said they can get a dermatomyositis pretty easily, but it probably wasn't this in this case. And by the way, a myositis can give you a CK that high, right? When you have that degree of muscle inflammation and damage to the muscle membrane. So then we finally decided it was probably more likely in muscular dystrophy because most congenital myopathies don't give UCKs quite this high, even though technically he doesn't fulfill the criteria for a muscular dystrophy where you have to have progressive proximal weakness. And this kid was asymptomatic. Now, we did say that there are some very rare muscular dystrophies which are asymptomatic, and this kid could have had one of them. So it turns out when you actually when you examine the kid, he truly did a normal exam. He didn't even have the gowns, right? And obviously with the child, they may not give you full effort, right? Everybody here has examined the kid or will examine a kid, right? They don't always give you full effort on strength testing and confrontation testing. What you want to do is you want to do other maneuvers that the kid will probably allow you to do. So one of them is the gowns. Now, true gowns is you actually have to lie them supine on the floor and then time it takes for them to actually rise from the ground. So not from a chair, not seated, but actually lying supine. This kid didn't have it. It's very sensitive to Gowers. You can also have them do deep knee bends. And again, people with myopathies, muscular dystrophy is going to be a problem. What I think a lot of kids actually like to do is hop, like hop on a foot and see if they can do that. Again, very hard if you have a myopathy or muscular dystrophy. A close second to that would be using stairs. So if the kid can run up and down the stairs, especially up the stairs, they don't have proximal weakness. If the kid has to hold on to a handrail, that's a problem. And one of the earlier signs of Duchenne muscular dystrophy is that the kid is having trouble climbing stairs. So you always want to look at that. And in fact, some of the outcome scores that we now use for Duchenne muscular dystrophy is the time it takes to climb 4 stairs and the time it takes to actually rise from a supine position, a true Gowers. And obviously, the weaker you are, the more time it will take. So we actually did a muscle biopsy. This was back in about 2013, the dark ages, before we had the genetic testing that we have today. So we did a biopsy. Sorry? Muscle. The quadriceps. So usually we pick a proximal muscle. And again, you could argue this kid didn't have any weakness. So which muscle do you choose, right? Usually you want to choose an affected, but not completely atrophic muscle. But this kid was completely blind. Now, in 2023, well, first of all, I would have done genetics. But if I didn't have access to genetics, I might have actually done an MRI to look for actually subtle atrophy, which MRI is actually very good at showing. So you can look at the shoulder or the hip, pelvic regions, and you can actually see, and you can biopsy a slightly atrophic muscle. But we didn't have that, so we just went blind. And we didn't see a muscular dystrophy. In other words, we didn't see lack of a protein consistent with the muscular dystrophy. And remember, every muscular dystrophy lacks a specific protein you can stain for. We didn't see any evidence of inflammation, no inflammatory cells, which we'll talk about on Thursday. And like I said, the stain for all of these different proteins completely normal. And then we want to make sure that this wasn't a metabolic myopathy, which would be unusual because they don't usually have CKs this high. And we stain for all of these different enzymes that are involved in different functions, different metabolic functions, and they were all normal. So this was the dilemma I faced back about 10, maybe 11 years ago. So then the question is what do you do next, right? You just did a muscle biopsy, normal. You stained for everything, normal. CK is 16,000. And by the way, the pediatricians call me every month asking for the results. The only time I've ever, and I don't know, Danny, what your experience has been, the only time I've ever had a pediatrician reach out to me on a consistent basis. Usually they'll reach out once, and I get it because they're busy. But this is every single month he reached out to me. And I give him a lot of credit for it because he made me think. So it was a bit of a dilemma. I actually didn't know what to do for many months. And I felt bad because I had to keep telling the pediatricians. So then what I finally did, so I referred him to genetics. I'm not stupid. And they couldn't find the cause. So then what I finally did is I sat down and actually looked at all the proteins that we stained for. And it turns out that if you look at the list of proteins that I mentioned over here, the gene product, right, look at that whole list. And they didn't stain for that whole list, right? No lab will do that because it's very expensive. Right? Remember, every stain costs money. So they weren't going to do this. So instead, what I did is I looked at all of the proteins that are involved in the more common muscular dystrophies and saw if we stained for them. And it turned out we missed one for calpain, which is, we're going to talk about in a minute. And it turns out that he had 2 mutations. So he actually had what we call compound heterozygous mutation. He had 2 different mutations that together, each allele was non-functional. So he had what we call limb-girdle muscular dystrophy 2A, the recessive type, which is actually one of the more common muscular dystrophies. So we actually made a diagnosis. The pediatrician was very happy because we had a name for it. I'm not sure mom was so happy. On the other hand, at some point he was probably going to become symptomatic. It's better that we have an answer than that we don't. So now you could have argued maybe he didn't have limb-girdle in the first place. And this is a differential diagnosis of diseases that mimic limb-girdle muscular dystrophies. So you could argue, like, what do you mean myasthenia gravis, right? Myasthenia gravis, it fluctuates, right? There's diurnal variability, but it turns out if you have chronic myasthenia gravis, you actually have permanent improvements, right? Once you have chronic myasthenia gravis, you basically destroy the AChR antibodies and receptors on the muscle membrane. They disappear, and then you can't have AChR bind to them anymore, and you just have fixed weakness. So again, very rare, probably not the most common possibility. But could this be Duchenne, right? The kid is 4, CK is 16,000, sure. You know, obviously you can stain for that on a muscle biopsy. Then there's certain myopathies that also can mimic this. FSH muscular dystrophy is another muscular dystrophy, which we may talk about later in the week. And then we've already spoken about some of the metabolic myopathies like Pompe's disease, which again, you can stain for. Now, the only caveat to the metabolic myopathies is sometimes the muscle biopsy can be relatively normal. So Dr. Morazin, I don't know if any of you guys know, was one of our former attendants. So she had a patient who she was trained for epilepsy, who was in her 30s. And then she realized that she couldn't climb up on the exam table. And she said, why can't you climb up on the exam table? It wasn't like 10 feet high. She's like, I don't know, I'm having a little bit more trouble climbing the stairs, climbing up on the exam table. And Dr. Morazin did a muscle biopsy of quad and actually found pools of glycogen, which is consistent with a glycogen storage disorder like Pompe's. And this woman actually had late onset Pompe's disease, but she was lucky because 50% of the time you see nothing normal on the muscle biopsy. So you can have a clean muscle biopsy like this kid, and you theoretically can have a metabolic myopathy. So the absence of abnormality, right, the negative predictive value is actually very poor for metabolic myopathy. If you see pools of glycogen, sure, it's Pompe's disease. But if you see nothing, it doesn't mean that it's not metabolic myopathy.
And the seizure was unrelated.
The seizure was only unrelated. And it was not from her antibiotics. It's Dr. McAfee, the arrested case, used to say you're allowed to have measles and a broken leg. You're allowed to have 2 different diseases. I understand for the medical students, this is a bit mind-blowing, right? Occam's razor, everything's one disease, but it's actually not true. You know, you're allowed to have more than one disease, which makes things very hard sometimes to make a diagnosis. So the limb-girdle ones, and we're going to do sort of a very brief overview of the different subtypes, because like I said, there's 75 out there. We're obviously not going to go through all of them. But usually limb-girdle ones, the dominant ones, they have lower CK levels, and they're usually less common than the recessive ones, than the limb-girdle muscular dystrophy 2s, just in general. Okay, and let me see, actually, let me do a slideshow. Okay, so yeah. So the ones to know for the limb-girdle ones, I would say are probably 1A and 1B. So 1A is a deficiency in what's called myotilin, and that's involved in the sarcomere that's part of the actin-myosin complex. So it's a problem with contractility. And the reason that's important is this can present with the muscular dystrophy, with weakness, but it can also separately in different people, not in the same person, also cause a distal myopathy. This is this variability that I was telling you about, this phenotypic variability, and even rarely can cause an asymptomatic increased CK. So this is what makes it so hard. You could have 3 people, same mutation, 3 completely different phenotypes. One could have proximal muscular dystrophy weakness, one could have distal myopathy weakness, one could have no weakness. Same mutation. Right? So it can be very hard to make a diagnosis.
Anziska, the CK level is not related to the severity, basically?
No, it is not. That's a very good question. No, it is not. It is not. We don't track it over time. It's not related to the severity of disease now. Now, I will say probably the more severe limb-girdle muscular dystrophies usually have higher CK levels, but it's not strict correlation. No. So these patients can have a very distinct dysarthric speech almost no muscular dystrophy has. Most muscular dystrophies, remember, don't affect the face, the bulbar muscles, etc. The vast majority. So it's very odd to see this. And sometimes you can have weakness or dysarthria. So you can have one or the other. And again, obviously not every dysarthric patient has a limb girdle, right, 1A, but something to keep in mind. And again, when you're thinking of muscular dystrophies, you're thinking of what stands out, not what's the pattern of weakness, because that may not help you at all. Congratulations. There's proximal weakness. That's every muscular dystrophy. But if they have a dysarthria, facial weakness, or something else, that helps you make a diagnosis. And Matt Woodland, whose talk this is adapted from, who's a University of Colorado, just stepped down to study neuromuscular, he claimed he was able to make a clinical diagnosis of limb girdle muscular dystrophy, the subject, just from the clinical presentation, without using an MRI to look at muscles or genetic testing, etc. I am not that good, but something to keep in mind. So limb girdle 1B is also very important because this one involves the nucleus. So it's a problem with nuclear architecture. Again, nothing to do with the muscle membrane or the dystrophin dystrophin complex at all. This is the nuclear membrane itself. And this one is very similar to Emery-Dreifuss muscular dystrophy, which we're going to talk about in a few slides. So these patients have very, very, very severe contractions. So if you see somebody with very severe contractions, weakness, and the contractions are disproportionate to weakness. And I'm talking about contractions like you can't move the joints at all, right? Or they have a rigid spine, a bamboo spine, those kind of things. You can't, it's you just can't move the spine at all. There's no flexibility. That would be consistent with Emery-Dreifuss, to be consistent with this limb girdle 1B. The other danger for this disease is that most muscular dystrophies do not affect the heart. Now, I did say that 1A can occasionally have cardiomyopathy, but 85, 90% of muscular dystrophies do not affect the heart. Thank God. You can only imagine, right? This one not only does it, it frequently affects it. Now, 2/3 of the patients have conduction defects. So in that respect, it's like myotonic dystrophy. And remember, conduction defects can kill you, right? You have complete heart block, that's it. End the pain, right? You have tachy or bradyarrhythmias, that's not good, right? You can have a cardiomyopathy and survive. And they do a quarter have a cardiomyopathy. You don't die from that, at least initially. But if you have conduction defect, that's it. And it can happen at any time, right? It's not like you have a warning necessarily that, you just had, non-sustained VTAC or something, time to go to the cardiologist. Somebody may just have, complete heart block and, they're dead 5 minutes later. So this is an extremely worrisome disease. I think everyone can appreciate that. So when you hear cardiac involvement, again, there's very few muscular dystrophies, and 1B would be the one that you would turn to first. So then the question is should you just put a defibrillator in every one of these patients? The electrophysiology docs would be happy to do that, right? That's for business. Is it cost effective? Is it effective? Nobody knows. So usually I punt this and I send them to an electrophysiologist like Dr. Budzikowski here at Downstate. And usually I leave it up to them, and they'll sometimes do loop recorders and other kind of stuff, and I don't know, throw dice and throw darts. I don't know how they finally make their final decision, because like I said, you don't always have warning of abnormalities. So these are examples of the contractures. You can see the rigid spine over here. Okay, so in this case, he's already very lordotic. You can see that he can't extend his elbows. So this is a kid, right? You can see his knees, right? They're already flexed, right? And this is, when I say contractures, I mean, you need surgery to undo this, right? This isn't rigidity. This is complete contraction. You can see the spine over here again. You can see the foot drop over here. You can also see the atrophy over here too. And this one you also can't see very well, but I think this patient is having problems extending his neck. And I actually had a patient who had the opposite. She had a hyperextended neck. So she would walk around like this. She couldn't even look at people. So Dr. Polino, who's one of the spine surgeons here, he literally unhinged her neck. Like he went in there surgically and just went in C1, C2, just sort of restored the normal, cervical lordosis, which sounds pretty brutal. And this was already a patient who had ventilatory weakness because of her muscular dystrophy, but she made it through and she survived. She's still alive today. She still got extremely severe contractions. And somehow, I don't even know how she gave birth a few years ago. I have no idea how that happens, but she's got severe contractions in both her arms and her legs and her spine. So she's actually got scoliosis. And then I think we'll talk about 1C. And 1C actually involves the caveolae, which are involved in the plasma membrane. They're involved in things like membrane trafficking. So this is more of an overall function protein. And the reason to know this one is, again, it can present, I know I sound like a broken record, but it can present, again, with a lot of phenotypic variability. The classic limb girdle weakness, what's called rippling muscle disease, where the muscle literally moves. That's why it's called rippling. You don't always have to have weakness. These patients will complain of twitching, but it's not true twitching. It's literally a rippling muscle. It could be a distal weakness, or like I said, it could be asymptomatic. What we call hypersleukemia. So hypersleukemia is a term. We have an elevated CPK, but you're completely asymptomatic. So many of these patients are completely normal. They just have elevated CPKs. Sometimes it can be toxic related, medication related. Sometimes it can actually be a warning of an underlying muscular dystrophy. But the vast majority of them are usually asymptomatic. So they could present like that. And then finally, it could be a hypertrophic cardiomyopathy. So again, most of them present with cardiomyopathies, but in this case, again. Okay, so moving on to 2. Okay, so for the limb girdle 2, usually the CK levels are higher, and they usually have, it's more common. So if you're going to see a muscular dystrophy, it's probably going to be limb girdle 2. That's probably going to be true for the boards as well. We're probably going to test you on limb girdle 2, not 1s. So calpain is the one that this boy had in this case. And usually the CKs are not quite that high, like this kid had, but they're still elevated. Usually they have dystrophic fibers, okay? And it's probably the most common muscular dystrophy overall. So it's probably worth knowing about just because it makes up 20 to 30% of all muscular dystrophies, which is pretty common. So it's worth knowing a little bit about. And it presents usually, usually in the pediatric years, but it can present, you see the range, right? I mean, usually I don't see 55-year-olds with it, but very rare. But could you see a 20-year-old with it? Absolutely. Could you see a 21-year-old technically in adults? Absolutely. So again, you guys have to know it. Now, this is scapular winging. Now, if you hear scapular winging, you think fascial scapular or muscular dystrophy, you should. But it turns out if you have proximal weakness, you can get scapular winging, and this can apply to many muscular dystrophies, including this. It can also present in Duchenne muscular dystrophy, because again, you have proximal weakness. They also have toe walking. And again, it doesn't mean they have Duchenne muscular dystrophy. You can see toe walking in certain muscular dystrophies. Remember I said patterns of weakness. On Monday, we spoke about scapuloperoneal patterns of weakness. So weakness of the scapula, scapular winging, and peroneal weakness, foot drop, problems with eversion. So you actually see toe walking in many muscular dystrophies, but we know it's not a neuropathy or something else because they have proximal weakness of their arms and legs. And then these patients can even sometimes have finger extensor weakness, and they can have contractures of the elbow, wrist, and fingers. So the reason that I put this slide up, I don't really expect what you see in the bowls to memorize it, but again, this unusual pattern of weakness. So yeah, they get proximal weakness, but they also get very severe adductor weakness. They can't bring their legs together. They have hip adductor weakness. That's unusual for a muscular dystrophy, right? They have weakness of their glute maximus, which if you remember, extends, right? It kicks back your leg. That's unusual for a muscular dystrophy, at least initially. That this is what that's what we were saying before, that certain doctors, if they're very skilled, might be able to make a clinical diagnosis of limb girdle muscular dystrophy. Because if you look at these unusual muscle involvement in terms of weakness and atrophy, that will help you, make the diagnosis. So that's what Dr. Whitney meant. He said you didn't need genetic testing because it's very unusual to see this pattern of weakness, and this would point you towards limb girdle 2A. Now, they do become wheelchair bound, so this is after decades, okay? And like I said, people will sometimes think it's Duchenne because they have, toe walking and weakness and CKs that are elevated and things like that. And it's the problem because I had a patient come to me and their referring doctor said it was Duchenne because you have an elevated CK and you're toe walking. And it turns out genetic testing was this. And the parents were sort of stuck on that it's Duchenne. And the problem is Duchenne, as you guys all know, has treatment. You use steroids. There's no treatment, unfortunately, for limb-girdle muscular dystrophies, steroids or otherwise. And again, this is just showing on MRI the patterns of weakness and atrophy. And you can see over here, this is the posterior compartment, the posterior muscles, which are most affected. So this is starting at the hip, going down to the calf, and you just see the pattern of atrophic muscles. And again, people use MRI frequently to show this pattern of involvement of atrophy because it's extremely sensitive MRI. And this is just showing scapular winging, showing superior abdomen. This is actually showing atrophy of the pectoral muscle over here. This is showing your scapular winging. This is showing the foot drop and the weakness of your ankle muscles, the atrophy. And again, you can diagnose it by staining for the protein, but these days you do genetic testing. 2D is also a very important one. It's called the dysferlin mutation. It's responsible for membrane repair. So again, it's not pure muscle related. It's also very common. So probably 2A is the most common, 2B is next. And again, it can present, with different phenotypes, even within the same family, usually very high CPKs. And again, this is used for Duchenne for the same reason, very high CPKs. It can present with distal weakness, it can present with proximal weakness. Usually the legs are affected before the arms, and usually you lose ambulation after 3 decades or so. And luckily, there's no cardiac manifestations on 2A. So 2B, absolutely nothing to worry about. And these patients, what's confusing is sometimes you'll see inflammation on biopsy, but it's not a myositis. Okay? Some people use steroids for 2B, and it's helped transiently, but at the end of the day, it's not like Duchenne. It loses at the head pretty common. And this is just what's called the diamond on the quadriceps sign, because you sort of see this bunching up of the quadriceps over here and over here. And then I've never seen this. This is just pictures. I'm going to treat these patients. I haven't seen that. This is the wasting of the intrinsic muscles, wasting of the distal leg muscles. And again, similar pattern of weakness you can see over here. So 2C to 2F are circle bypass. The only reason to know about these ones is people are actually starting gene therapy trials for these, for 2C to 2F. So again, these are like phase 1, so I won't get too excited just yet, but it's literally, the first time we've ever come up with any therapy for these. It's, as we were talking about, there aren't that many gene therapies out there, because Duchenne has one, so this is coming up on the horizon. We'll be ready by the time everybody here graduates from residency, maybe the phase 1 trials. I'm not sure about phase 2 and 3, but definitely phase 1. We'll know if it's like that. What we know if it helps, probably not by the time you guys finish residency. It'll take probably a few more years. And again, the sarcoglycan, if you remember, that links the extracellular matrix to the cytoskeleton. So it's a pretty important part of the muscle structure. And again, this is just showing the sarcoglycan over here. And again, it's confused for Duchenne frequently because you get calf hypertrophy. So remember, Duchenne is calf hypertrophy. It can present very early in life like Duchenne. It can present later in life almost like a Becker's. A lot of aches and pains and cramps. Some of them are asymptomatic. Some of them do have a cardiomyopathy. So again, it can be a lot of phenotypic variability. And like we're saying, some of them actually do develop cardiac dysfunction, and they can have relatively high CKs. So I'm going to skip some of the others. And we talk about, different testing algorithms. And I will say, Dr. Wickman came up with this slide about 8 years ago. I would say in 2023, I wouldn't even see it. And what do I mean by that? You have a patient with proximal weakness. You think it's limb-girdle muscular dystrophy. Either it's dominant because of the family history or recessive because of the family history. And you have no idea which one it is. And you vaguely remember my lecture. This is a few years down the road. And you're like, patterns of weakness, and certain muscles were affected, and I can't remember which goes to what, and the CKs are high. You're like, it's gotta be muscle, right? And you're thinking, probably not a myositis, probably inherited. So you're thinking, could this be a muscular dystrophy? So the short answer is, there's actually panels now that test for all of these muscular dystrophies. So you don't even have to think it through. You could send it all off and test for 50 muscular dystrophies like that. I just did it this morning for a kid. And I would say that even myself, and I know a little bit about muscular dystrophy, you can be fooled, right? You can look at somebody and say, oh, it's Duchenne, and it's nonverbal to, to C, or vice versa. So you don't want to be too clever, and then you just order a panel. You actually can do it free through PTA Genetics. So pediatricians know this in the room, and you guys were rotated on peds know that. It's called DTECT, muscular dystrophy, I think is the name of the test, and you just send it off. So, but before then, you sort of have this algorithm of which ones to test for, right? If you're male, obviously you think of Becker's or Duchenne. If you're female and you have very high CK levels, you think for sarcoglycans. If the sarcoglycans are normal, you check for dysferlin. If dysferlin's abnormal, then it's probably 2B. Dysferlin's normal, you can check for 2A, etc. But these days, you just do a genetic test. And again, when we talk about genetic testing, you don't have to do whole exome or whole genome sequencing. Not for this. You do what we call targeted gene panels, which include the genes that are involved in the muscular dystrophies. Okay, and who decides that? Usually the geneticist who works for that testing panel. Okay, so you don't have to think of it. So is there a need for muscle biopsy in 2023? I would say for muscular dystrophy, no. I would say no. Do CPK testing, look at the phenotype, the age and sex, and then rationally order genetic testing. I think for invasive procedure, especially for a pediatric patient, I would not recommend this. Now, some people have said, like for Duchenne, for example, you have patients, you've done the genetic testing, they're not behaving like a classic Duchenne patients. In that case, you could, let's say, stain for dystrophy. And let's say they have a Duchenne mutation, but somehow magically they're actually making some dystrophy, and that may be why they have a mild phenotype. But in general, you don't really need to do muscle biopsy to make the diagnosis. Okay, you really can use genetic testing for that, and I think you should, because obviously a buccal swab is much better than an invasive test, especially on a kid. And then in terms of the treatment, like I said, unfortunately, there's no medical therapy yet. It's important, especially if you have foot drops, to use orthotics and foot orthotics. And again, this shouldn't be overlooked. I see people who literally come in with, toe walking, ankle contractures, just nobody bothers to give them an orthotic. And again, as a neurologist, nobody's expecting you to order your orthotic, but just send them to somebody who can. Send them to rehab or physical therapy or whoever. Trust me, work is out, we will be more than happy for visits, I promise. Many of these patients do have ventilatory weakness, both lingural 1 and lingural 2, because again, the diaphragm is affected. So these patients will frequently need what we call a hypothesis, insufflator, exsufflator, like I said on Monday, to help you expectorate to cough out. They may also need BiPAP or non-invasive ventilation at night. And again, if they end up, God forbid, in a unit, it may be very hard to extubate these patients because they don't have good vital capacity. So it's something to keep in mind. And the very unfortunate ones who also have facial weakness, it's really hard, right? Because they can't even form tight seals to test their breathing, and etc. And then the ones who have cardiac involvements, so that's some of the lingural 2s, Duchenne, some of the lingural 1s, obviously they have to go to cardiologists for Holter monitoring, loop recorder, echo, etc., to obviously make sure there's no problems. And these patients can safely exercise. One of the big problems that we see with our muscular dystrophy patients is, and myopathy patients, is they're not exercising. Because neurologists tell them, oh, it's making the muscle worse. And that's true if you're going to do severe weight training, right? Nobody's expecting you to go out to the gym and bulk up. We're running a marathon, but you can exercise with a reason. And these patients will become deconditioned if you don't. And then they'll become even weaker. And then it's a vicious cycle. Then they don't want to walk because they're deconditioned, which is bad. So again, you can do this safely. There are clinical trials going on, like I mentioned, including gene therapies. They're using AAV vectors like we spoke about on Monday. People have even been using stem cells. This is a phase 1 trial for 2C. There's a few others going on with a company called Sarepta, with origin transfer. And people have even tried to transplant stem cells, which can then differentiate into muscle cells. Hasn't really worked out so well yet, but people are still trying. So there are different organizations that obviously help these patients, including the Muscular Dystrophy Association. So they're sponsoring this research. So I will stop there. Be happy to take any questions from the audience here or online. Or maybe I was super clear.
So if some of these can present this
Yes.
So why do you still call them limb girdle? Is it because
You really should. You really should, because the vast majority of the time they are proximal, but they do have this allelic phenotypic variability. So yes, so not all distal weakness is neurogenic. There are neuron can be muscle, and then it could be a distal myopathy, or it can even be one of these genes that are involved. Yes, which makes it hard. I'm not gonna lie to you sometimes to make the diagnosis.
And Duchenne is not one of them, just as a matter of classification.
Yeah, it's a matter of classification. It was taken out of the limb world because it's so common and it's sort of on its own and it's treatable and for other reasons. It's sort of in its own family.
So for limb girdle, when they labeled as one, they're autosomal dominant, two, and they're recessive, right?
Exactly.
But the 2AB are more common than the one.
Exactly.
Recessive.
Yeah, why that is recessive, I don't know. It's also in different ethnicities around the world. And I didn't get into this, but certain ethnicities have higher gene frequencies, which determine these muscular dystrophy. So like those values that quoted were among Caucasians in the US. So that may not be true across the board for the US, right?
And they always need to be followed at MDA clinic.
They should be, because you really want a multidisciplinary clinic.
Yes.
You also need neurologists who actually know what you're looking for.
Yes.
So I would recommend it. Yes. Obviously, if you're in Wyoming, the nearest MD clinic is 5 hours away. I wouldn't necessarily ship them off there. But ideally, that's the whole rationale for the Muscular Dystrophy Association network. And there's an MD clinic in every state, in every territory, so everywhere. That wasn't an ad for the MDA, but yes. Just to let you know about it.
When we do the genetic testing, is it the penetrance is 100%? So when you have genes abnormality, you usually have a disease.
So it's a pretty good yield because they actually do the sequencing. So they don't just look at like deletion duplication, they actually sequence the gene. You can still occasionally miss. There's certain mutations that we call variants of significance, uncertain significance. So there's a change in the DNA. You don't know if that causes a pathogenic process. So those are the tricky ones. So if it's a pathogenic mutation, that's good. But if it's a variant of uncertain significance, it could be pathogenic. We don't know necessarily. That's hard. So we've made diagnoses actually where we've seen a homozygous mutation, both alleles, which is variant of unknown significance, then we tested the parents, they were carriers, and then the child did both, and then you can sometimes predict how that will affect protein. What sites are affected because of the mutation. Is it a conserved region? Is it going to affect the protein function? Usually, if it's a conserved region, it will affect protein function. Change with the amino acid, it changes, with positive to negative and things like that. That's frequently a pathogenic mutation. But sometimes it's hard. I see variants of uncertain significance all the time.
How sensitive are these panels? If it's negative, would you just say yes? It's not.
Well, again, you should always look. I mean, this could be the muscular dystrophy 71st. You know what I mean? And we have had ones that we've gone back after the fact, and we made a diagnosis because 8 years ago they didn't have the gene. So I wouldn't say never, but yes, I would say so.
Did you have to go back for muscle biopsy if the genetic testing was inconclusive at some point?
You could, but again, the limitation is you have to stain the right proteins.
Yeah.
That's the problem. These days, there's so many different proteins, almost no labs can stain for them. If anything, they're cutting labs, many of them actually got rid of their muscle lab. So there's fewer and fewer than there are around. So these days, the muscle labs are basically for like myositis, occasionally sarcoid or some other weird myopathy, not for inherited processes. And if you're really not sure, I guess you could do a whole exome, a whole genomic. We don't usually, at least not to start. Question. So the moral of the story is you have to know neurogenetics, right? No, you actually question you need to know neurogenetics. At least you know Muscular, 100% with the therapies that we're giving, like gene therapy, SN15, you have to know what you're giving, right? So therefore you have to understand genetics. So for the med students, it's not too late. They need to do a lot in med school. For the residents, it's not too late, Yeah, it's on your boards, and you can teach yourself. I mean, Dr. Tillman, may rest in peace, my father, they didn't, like I said, they were just coming out with DNA, when they were in training or in my fellow's case, a little bit after he started training, a little before he started training, you know, you can obviously keep your scope is very important. Now, obviously, you have to look at other aspects of neurology, movement disorders, etc. But for neuromuscular diseases, if it's not something autoimmune like myasthenia, it's pretty much it. Generalopathy, SMA, muscular dystrophies, inherited neuropathies, all the CNCs, list goes on and on and on and on. So, you know, you can't be like a neurologist, you know, the ends, right? And all the new therapies that are coming out, we're gonna have more gene therapies, more extensive gene therapies, etc. You know, or even small molecule therapies that target a certain function of the gene. You know, you have to understand this. Just have to. I mean, if you want to be a doctor, you know, go to PA school, you know. No, serious. So it's very, very important, you know. And sometimes I see residents don't always understand when I'm going through the intricacies of genetics, and this is all fuck on. I mean, when I went to med school, we didn't want to know teaching genetic class, right? This was 1997 when I was first or second year. I mean, obviously they had DNA, not that. But, you know, they just did a lot of the therapies, they didn't have genes, they didn't know what caused nighttime dystrophy, they just figured out Duchenne. A lot of these things were on the horizon, you know, so obviously you have to learn. Okay, so now that I have horizons, we'll leave it at that. Okay, thanks for coming, and I'll see you guys tomorrow.
Thank you so much.
Thank you, Dr.
My pleasure, guys.